Hey everybody, welcome back. This is the last of our upper extremity lessons. We've covered shoulder, we've covered elbow, we will cover wrist and hand. All that leaves for us is spine. So if you're looking for the $3 word of the day, this is our penultimate lesson. That means next to last if you didn't know. But it's been a pleasure so far. Hopefully you've learned a lot. And as you've seen so far, much of what we do is very similar from body part to body part. We use that same systematic approach, and it is effective in helping us identify what the problem is and then subsequently treating it. So without further ado, let's get right into wrist and hand. Now, our surface anatomy at the wrist and hand is obviously easier than it was at, say, the shoulder or at the hip because we're more distal. And as we get more distal, our structures become easier to see. So by the time we get to the wrist and hand, a lot of our tendons are readily apparent. So one structure you're going to want to take a look at in particular is what's referred to as the anatomical snuff box. I don't know if you can see that or not, but it is formed by the borders of the abductor pollicis longus and the extensor pollicis brevis tendons that make their way out to the thumb. And we'll talk about the significance of the anatomical snuff box a little bit later. There are other tendons that we should be aware of, as well as some other soft tissue in the wrist and hand. But just rest assured in knowing that usually by the time we get to pain out in the wrist and hand, if your patient's able to pinpoint exactly where that is, usually we're pretty good at localizing that pain. Where it hurts is where the pathology is. The same doesn't hold true as we get closer to the spinal cord. It becomes increasingly difficult to pinpoint the source of our pain. So that actually serves us well as an evaluator because we can rely on our findings quite a bit better. Now our HOPS applies to the wrist and hand just like it did everywhere else, so our history questions are very similar. What was the cause of the pain? What were the symptoms at the time of injury? Did you feel them after? Did you feel them during? Any swelling or discoloration, just like we talked about at the elbow. Swelling usually is easy to see because it is angular. It's a body part that's readily seen all the way around, unlike the shoulder or the hip. What treatment did they give? How does it feel now? Any previous injuries? For observations, we take a look, our visual inspection. We look for deformities, differences left or right. We look for swelling or other skin defects, and we run them through a quick range of motion. So we'll do what's called a Phelan's test, where they'll actually go back of the hand to back of the hand, try to get the elbows as low as possible, and then a reverse Phelan test is kind of prayer hands, and that lets us see if there's a difference. And if one elbow is way below the other, then that tells me I don't have as much flexion on this side. Same thing holds true. If I can get one elbow higher, I know I've got more extension there. I'll palpate at sites away from the injuries. If they tell me it hurts here, I'll probably start at their elbow and work my way systematically down, looking for tenderness, looking for obvious differences left to right. And for that matter, I'll probably start on the non-involved side first, just to get a feel for what their normal anatomy should feel like. So as always, we've got a list of our bony and soft tissue anatomy. Make sure you take a look in the textbook and potentially could identify these structures on a diagram if asked for that upcoming final exam. Some other palpation spots we want to take a look at is our soft tissue. Okay, so take a look there. Now, it seems like every time we do a body part, we start with contusions. Same thing holds true here. A bruise is a bruise is a bruise is a bruise. At the wrist and at the forearm, we know that the ulnar side gets the majority of the blows due to our tendency to try to protect ourselves. These can be acute or chronic. We can have issues with this. There's not a lot of soft tissue overlying the bone at the forearm, so these can become pretty debilitating. We can end up with heavy fibrosis here, even a bony callus with a hematoma, just like we talked about with quad contusions. So we do want to take care of these, maintain adequate treatment here, try to get that swelling out of that body part as rapidly as we can. Protecting this injury from further trauma is critical, so a hard shell pad, sponge rubber, or some sports actually will allow you to wear protective equipment. We have to be careful here because in a sport like basketball, we can't wear a non-yielding, hard shell pad on the forearm. That's where our sponge rubber would be okay, with maybe a sleeve over the top of it. Okay, forearm splints, we talked about shin splints with the lower extremity. Forearm splints are very similar, kind of a nondescript arm pain that we have. It can come from a strong static contraction. We can actually end up with an irritation to the periosteum over the bone. They may end up with weakness and pain with contraction. We're going to treat this symptomatically. If it hurts a lot, we're going to treat it. Usually this will respond pretty favorably to conservative management. This can turn into a compartment syndrome. We talked last time about a Volkmann's contracture, so we want to be cautious here that we're not overlooking it and writing it off as just forearm splints when it is in fact something more serious. Forearm fractures, these oftentimes occur due to a fall on an outstretched hand. You'll see this in skateboarders and BMX or bike riders that fall off their bike, athletes that trip and fall. They try to catch their fall and they fracture. The ulna and the radius generally fracture individually, so a compound fracture that involves both bones, it's not unheard of, but it certainly is possible that they'll fracture one or the other and not both. A fracture in the upper third may result in an abduction deformity due to the pull of the pronator teres, so that's going to have to be reduced in order to heal properly. Just like with other fractures we've talked about, oftentimes the patient will describe an audible pop or a crack that's followed by moderate to severe pain, swelling, disability. We're going to splint this in the position that we find it and refer them for care. And as long as that can be reduced favorably and we get good approximation of the bones, then they'll just be casted. This wouldn't necessarily be something that has to be surgically pinned or screwed or fixated otherwise. A Colles fracture is a specific type of fracture in the arm. This is in the distal radius or ulna. The mechanism is a fall on the outstretched hand with the hand in extension. A less common fracture is the Smith fracture. We tend to land with our wrists in extension, so less common is a Smith fracture. This is an anterior displacement of that distal fragment. If the joint itself is involved, so here we've got an injury near the growth plate. If the joint itself is involved, then that's referred to as a Barton fracture. With the Colles fracture, usually they're going to have a displacement of the radius. We end up with what's called a silver fork deformity. So instead of it being straight, we actually have kind of a bump on the posterior side. When there's no deformity, lots of times we'll write this off as just a bad sprain. This may result in extensive bleeding. So if they don't have an open fracture, then that's just going to be bruising and swelling. We may end up with tendinous avulsion or tears, and also the possibility of median nerve damage. Okay, we're going to manage this with cold and immobilization. Refer this right away. And even if it's a sprain, a severe sprain, we're going to treat that like a fracture. In a skeletally immature patient, this may cause a separation of that lower epiphyseal plate, so we want to be careful to treat this appropriately. Alright, that leads us to Madelung deformity. This one is not terribly common. It can be congenital, it can be acquired, but what happens here is the wrist is actually kind of slammed shut, so to speak, and it grows in an abnormal way. So we end up with changes in the radius and the ulna, and then the carpals themselves, their alignment is completely wrong. So we'll take a look at some differences that you might see. So this is a photo of a normal wrist. So we've got the radius here, thumb side, ulna here, and we see this central column where the lunate, capitate, and the middle finger all kind of line up and they bear load. Take a look at this patient. You see how instead of it being relatively flat across the joint line, they've got kind of this V shape or this chevron shaped carpus, and the lunate just kind of hangs out here, and if we bear force through here, it actually serves to spread the radius and ulna apart rather than to send load through it. So this entire wrist is unstable. We see this kind of palmar migration here where it doesn't line up in a nice flat line like a normal wrist would. This is actually a picture of a gymnast that I worked with at the University of Arizona. What happens here is they bear so much load through the hands. She was a vaulter from the time she was 3 or 4 years old. The epiphyseal plates get pinched shut. They are prematurely closed medially on the radius and laterally. Did I say that right? Let's see. Medially on the radius and laterally on the ulna. Centrally. So the middle of the wrist is kind of slammed shut. Meanwhile, the outer growth plates are still open, so it continues to grow in this we end up with this V shape, and it's terribly unstable. Making matters worse for this patient, she was an art major, she was a sculptor, so not using her hands was very difficult for her. She needed to use her hands for classes to graduate. She needed to use her hands to compete in gymnastics. So this one can be managed conservatively, but if in some cases they actually have to have a surgical repair where they take these V-shaped chunks out, resect this back down, and pin it back together. So that is basically our forearm. Okay, so from there we go to wrist and hand and fingers. Okay, so our history here is going to be much the same. You've heard these questions 1,000 times before. Nothing really different here in terms of observation. In terms of history. In terms of observation, we can see the wrist, hand, and fingers very easily. A little bit of swelling looks massive in the fingers. So we look at that. We also look at the color of the nail beds. We look for what's called capillary refill. So if you pinch that fingernail, you'll see it kind of blanches out, turns a lighter shade, and then once we remove the pressure, it should reperfuse and fill back up. Okay. Our bony palpations here, just be familiar with these. Take a look at the anatomy diagrams in the book. There's quite a bit here for you to take a look at. First special test we see here is called Finkelstein's test. Sorry for the overlap. This is a test for stenosing tenosynovitis in the thumb. So we put our thumb in our fist and we pull down, and we're looking for sharp or shooting pain in the wrist here. A positive sign is basically pain provocation. Tinel sign, we see this. We did a Tinel sign at the elbow. This would be the same type of test where we're just tapping over the nerve and we're looking to see if they have shooting pain. This may, unlike at the elbow where we did that test for ulnar nerve entrapment or ulnar neuropathy of some sort, when we do it at the wrist, this is a test for carpal tunnel. If we do it at the elbow, it could also be for cubital tunnel. Phelan's test, I already kind of showed you these. So a true Phelan's test is back of the hands together. A reverse Phelan is palms together. So with a Phelan's test, we're looking for range of motion, but we're also looking for pain. If this causes pain, this could be a compression injury to the median nerve, whereas if we have pain with extension, this is a tension sign for median nerve. Okay. Varus and valgus tests, we've done this at the elbow, we've done this at the knee. We're just assessing the stability of the ligaments of the wrist and the ligaments of the finger to try to identify whether or not they're having any problems. Okay, an Allen's test. This is a test for circulation through the hand that might be indicative of something like a vascular insufficiency to the distal extremity. Could also be a sign that they've got something like a proximal lesion, like an impingement. A thoracic outlet syndrome. So the patient will squeeze their hands 3 or 4 times to kind of wring blood. The examiner then compresses both the radial and ulnar arteries, and then the hand this is almost like a cap refill test, but we do it in the whole hand. So you see how this hand looks really white and blanched, and now it's red where it's reperfused, and that tells us they've got normal circulation. Some other tests we'll do for circulation and neuro, we can just check their hand temperature. We check cap refill. We do that Allen's test. Normal neurologic functioning should be tested, so sensory motor function, 2-point discrimination. There's lots of things we can do to test the integrity of the hand. Functionally, we just have them move through a range of motion, isolate each individual joint, move them through flexion and extension, have them do approximation, just looking to see, is the wrist and hand functioning as it should be. Okay, so as far as injuries go at the wrist, ironically, I just said we check contusions at every body part. We don't really do it at the wrist, although they could occur there. First thing we'll look at here is a wrist sprain. This is our most common wrist injury. This would be from any abnormal or forced movement. They could fall on a hyperextended wrist, a violent flexion. They could get their hand caught up with an opponent and get it twisted. So our biggest concern here is whether or not it's truly a sprain and making sure that it's not something more serious. So pain, swelling, difficulty with movement are all signs of a wrist sprain. Manage this by sending them for x-ray if there's any concern that it's a fracture. We will protect this, and we can splint it. This is referred to as a cock-up splint. It holds the wrist in slight extension. We'll have them begin strengthening right after the injury. We can tape this for support, and this can be done preventatively from that point forward. One big concern with diagnosing a wrist sprain is that we've missed something more serious, and one of our concerns is what's referred to as a TFCC injury, a triangular fibrocartilage complex injury. So this is ulnar side wrist pain. It doesn't respond to conservative management. Swelling is possible, but they usually won't swell much initially, and lots of times the patient won't even report this to you. They'll just assume they've got a minor sprain, and a couple weeks later they come to you and they're like, this wrist isn't getting any better. I've tried to tape it, I've tried a brace, I've tried a glove, but nothing's helping. So anytime we've got medial or ulnar side pain, we want to make sure and rule out a TFCC, because this is notoriously slow and poor healing, and oftentimes this is going to be a surgery if conservative management doesn't succeed. We said the de Quervain's test was for tenosynovitis. Unlike a tendonitis where the tendon itself is irritated, a tenosynovitis is the sheath around the tendon that gets irritated. And we have a lot of tenosynovium for the tendons in the wrist, so it's not uncommon that we irritate that tendon. So this could be acute pain and inflammation for a few days, but usually these will resolve pretty quickly. If it's true tendonitis, then one difference here is we might try some cross fiber friction massage to try to break some of that up. A tenosynovitis doesn't like that, but a tendonitis usually responds pretty well to that. Okay. Nerve entrapment, compression, nerve palsies, we see this in carpal tunnel primarily. So there can be more compression, entrapment, and palsies than just carpal tunnel. So anytime we get sharp, bright, shooting pain, skin sensitivity, we start to think there's at least some neurologic component to this. And palsy is going to be, periodic weakness, inability to use a given muscle group. Okay, so the most notable of this is carpal tunnel. Okay, so in this picture we see a normal, kind of fleshy, rounded, normal thenar eminence. Over time, without innervation, that muscle will actually waste away. So we end up with what's called thenar atrophy. It almost looks like a soup bowl in their hand, and this is two different patients showing you normal versus abnormal. This is the same patient showing you a positive sign for thenar atrophy in the left and a negative sign for a normal thenar eminence in the right. Okay, so that's kind of one of your biggest signs. They'll also complain of numbness and tingling that persists, especially during the night. If this persists, they might try to inject this first of all, and then if that doesn't work, then they might try a surgical decompression where they're actually going to cut that transverse carpal ligament, relieve the pressure, and allow the patient to return to activity. Problem with that is it leaves the wrist less stable. So for an athlete, that's not something we want to do right out of the box if we can avoid it. All right, that leads us to de Quervain's disease, sometimes called Hoffman's disease. We said this is a stenosing tenosynovitis. So stenosis means a narrowing. So that tendon sheath actually starts to kind of close in on the tendon itself. So that de Quervain's test would tell us whether or not we have this. So here you see these blue structures are the tenosynovium. You can see the cross section, so the tendon itself is in white. There's kind of a little space here in blue, and then the sheath in light blue. In a stenosing tenosynovitis, there's no space here. That tendon sheath actually kind of closes in on the tendon itself. So even though the tendon is healthy and happy, the sheath around it is irritated. So this can be painful. They can have trouble with grip strength. I said a positive de Quervain's test. Finkelstein's test is the name for that test. So anytime we get them in a position that puts tension across that structure, it's pretty painful. It hurts. So with this one, we would immobilize them for a while. This may be something that could be injected with a corticosteroid by a physician. Ultrasound and ice can be helpful here, and joint mobs can be beneficial just to help them maintain their range of motion. Okay, here we see a dislocated lunate. It's popped out of position. A forceful hyperextension or fall on an outstretched hand can result in that lunate dislocation. With Madelung's deformity, we talked about how that lunate should be central. It basically should be right in line with your big finger, and it's a primary bone for load bearing through the hand. In a case where we end up popping that bone out of position, this can become a big issue because there's really not a lot of room there for that bone to go somewhere without damaging ligaments and potentially being out of position and losing blood supply. If this isn't recognized early, then that bone can begin to deteriorate and it'll have to be surgically removed. So this is one we don't want to miss. So if they've got pain with palpation in the central aspect of the wrist, we might want to send them for x-rays just to rule this one out. Another one along that same line is Kienbock's disease. This is a lunate that's diseased and has lost blood supply. So if you look here, you see this big black dot right in the center that tells us that that lunate has died. We want a mobilization early on. This may need surgery in order to be properly repaired. So if you look, the blood supply to the carpals is somewhat tenuous. It's pretty easy to disrupt, and so a loss of blood to that lunate results in avascular necrosis. Similar happening instead of in the center of the wrist, in that anatomical snuff box that we talked about, is a scaphoid fracture. And again, it has a relatively poor blood supply, so if we've got a fracture in that and it goes undiagnosed, or we misdiagnose it as a wrist sprain, then that bone can be dying when it should be immobilized. When we should be managing it, we aren't, and it actually gets worse. Okay, so this oftentimes will present like a wrist sprain. The key here is pain in that anatomical snuff box, so we want to make sure we don't miss this one. They need to be splinted and referred for x-ray before they're casted. You see this patient's in a thumb spica cast. They'll be immobilized up to 6 weeks, followed by strengthening and taping, and they'll probably need wrist protection against impact loading for some additional time because this is a slow healing bone. Hamate fracture is another one we see in the wrist. That bony knob you feel at the base of your palm on the pinky side, on the ulnar side, is the hook of the hamate. So it's kind of out there. It's relatively prominent. So what happens here? We see this happen with golfers, with baseball players. The knob of the bat rests right on that hook of the hamate if you're not choking up, and it can lead to a fracture there. I've seen this happen in base runners as they're sliding into the bag. They jam their hand into the bag and fracture the hook of the hamate. What you see here is an axe handle bat. There's actually an aluminum bat company now called Axe, A-X-E, and the idea here is that that handle is ergonomically designed so that there's not a knob putting pressure on the hook of the hamate to protect the patient. So athletes, these are more popular than they once were. They're more readily available now. So some athletes are just using them because they're more comfortable, even though they've never fractured the hook of their hamate. There was a time when these were kind of hard to find, and after that fracture, they will continue to be really tender there. So protecting that area can be somewhat challenging. That said, we can use special gloves that have pads built in. This is a soccer goalie glove. Some batting gloves will have that palm guard. There are some donut pads that you can add that add some shock absorbent material. So there's lots of things we can try that protects that even after fracture. Another condition we deal with is the wrist ganglion. This is a synovial cyst. Usually we'll see this on the back of the wrist. It used to be called a Bible bump because this ganglion would form and they'd whack it with a big heavy book like a Bible, and it would rupture the cyst and it would go away for a time, but it would almost always come back. So whacking your wrist with a big heavy book is not the appropriate treatment for a wrist ganglion, even though it would give you some temporary relief. Pain increases with use. It may feel soft and rubbery, or it may feel like a bone under there. I felt both ways. I got one of these one year when I was taping a lot. My left wrist really got irritated, and so it was injected, and it responded pretty well. So we used to break that down with pressure. As we said, the old wives' approach was to break it with a heavy book. Another approach was to apply pressure, like thumb pressure, and then put a pad over it. Newer techniques, instead of applying pressure, we actually aspirate that, so the physician will draw the fluid out. They may cauterize it and then put a pressure pad on there. The most effective treatment, though, if this continues to come back and crop up, is surgical removal, but they can even still come back after that. Contusions and pressure injuries to the hand and fingers. So we didn't talk about contusions at the wrist, but at the hand and fingers, we see this a lot of times. The finger gets slammed in a car door, or gets smashed with a hammer, or smashed between two helmets. This certainly happens. So in the distal phalanx, we can end up with something like this. It's referred to as a subungual hematoma. And if you've ever had one of these, you know it almost feels like you can feel your pulse in that finger. So for that, we can use a cautery tool like this or a small drill bit and create a hole in the nail, which allows that little bit of blood that creates a lot of pain to come through the nail and subsequently relieve their pain. So this is it can be really, really painful, but it can be managed pretty easily as long as we catch it early. If this is a couple weeks old, then that's all coagulated, clotted, and it's not going anywhere. So even if we drill a hole, it's not going to help. The good news is usually by that point it doesn't really hurt anymore, so that's good. Trigger finger or trigger thumb, repeated motion in the fingers can result in irritation, resulting in some tenosynovitis. So that tendon sheath may be irritated. We'll treat this the same as De Quervain's. This is just a condition, similar condition in a different structure. If our conservative management is unsuccessful, then this can be injected and splinted. Okay. Another specific condition is what's called mallet finger. This can look like a little mallet, like a hammer. What happens here is the extensor tendon ruptures. So that patient's going to have a finger stuck in flexion distally, and they can't actively extend it because the tendon inserting there has been ruptured. Okay, so they're going to wear what's called a DIP, a distal interphalangeal joint splint, and this has to be done up to 6 to 8 weeks. And normally, as long as we can keep that distal phalanx in extension, that extensor tendon will scar down and it will heal normally. A similar condition here is called the boutonniere deformity. So instead of it being the distal most phalanx, it is the proximal interphalangeal joint. So we end up with, boutonniere is French for button hook, so we end up with a let's see if I can show you. So we end up with this kind of hook-shaped finger that's deformed. So they'll be put in a splint for the proximal interphalangeal joint. So remember, mallet finger, distal, boutonniere, proximal. It's really the same condition. It's a tendon rupture, but the question is which tendon is ruptured. So this too would be splinted up to 2 months, and usually that will heal relatively nicely. On the flexor side, we can end up with what's called jersey finger, and this is a rupture of the flexor digitorum profundus. So you see this bruising here. The patient isn't able to actively flex that DIP, and the finger is kind of stuck in extension. This one is not as easily fixed. We can't splint them in full flexion, so this is usually going to have to be repaired surgically. It's called jersey finger because what happens is patient grabs jersey and they are eccentrically pulled out into extension, so that flexor tendon is trying to pull. Meanwhile, the fingers are being extended, and we end up with a rupture. Okay. That leads us to Dupuytren's contracture. Here, this usually develops in the 4th or 5th finger. They end up with a flexion deformity. These nodules can be removed, and once they're removed, usually they will return back to normal function. So they end up kind of stuck in flexion, surgically corrected, they go back to normal. Gamekeeper's thumb, this one's named, interestingly enough, gamekeepers would shoot birds, and if this is my bird, my stapler is my bird, the bird wasn't dead, they'd want to break their neck to kind of finish them off, put them out of their misery, so they'd stick that thumb on their neck and try to snap over. Well, what happened is that resulted in instability to that ulnar collateral portion of the MCP joint. So they'll end up with pain over the UCL. We see this, I'm sorry, I'm showing you LCL. Pain over that UCL. We'll see this lots of times in patients who get their thumb caught in a jersey of an opponent, or see this in skiing. Their pole gets stuck and their thumb gets pulled out of position, so they end up with this gamekeeper's deformity. We don't want to treat this like just a sprain. If this doesn't start to feel better within a week or so, then we're going to want to refer this one. And that's kind of a message to recall for any of these conditions. If we treat it conservatively, we think it's just a sprain, and it doesn't start responding, then we probably have either missed the diagnosis altogether, or we haven't captured all of it. You know, yeah, there's a sprain, but it's more severe than just that. So this can be taped. This may require surgery. My daughter sustained a gamekeeper's thumb. We've been skiing as a family one time, and she managed to do it. So she still has a little pain because of it. A PIP, proximal interphalangeal joint dorsal dislocation, we see here. Lots of times this will occur in athletics. We see this pretty regularly in football, sports with a lot of hand-to-hand. We'll treat this with reduction. Athletic trainers are not supposed to be reducing joints. Usually the physician would be doing this, but these are usually pretty easy to resolve. They can do this on their own. A palmar dislocation, on the other hand, we see this finger is ring finger's out of position here. Palmar dislocation is going to come toward the palm. these are going to have to be reduced as well. And with any of these dislocations, these are going to have to be immobilized. They're probably going to want to tape these for quite a while, just because it's going to continue to be swollen and tender and hurt. Metacarpal phalangeal joint dislocation. This can be caused by a twisting or shearing force. Usually we're grabbing something and it's ripped from our hand, kind of like a jersey finger, but instead of resulting in a tendon avulsion, it results in a joint dislocation. So this is going to be splinted and reduced. Buddy taping can help with this. Okay. Metacarpal fractures, if it's in the fifth, it's called a boxer's fracture. You punch a wall, fracture that fifth metacarpal. We can have fractures elsewhere. They aren't necessarily called boxer's fractures if they are elsewhere. If there's an obvious deformity, it gets reduced. What we're hoping not to see is a fracture with rotation, because those are going to heal very poorly and might need something more than just splinting. They might actually need to be reduced open and pinned together, something along those lines. With a Bennett's fracture, we see this at the carpometacarpal joint. This can be a similar mechanism to a dislocation. Sometimes this can occur along with a dislocation. That carpometacarpal joint may appear to be somewhat deformed, and the x-ray will rule out whether or not we had a true fracture or a dislocation, or maybe both. Distal phalanx fracture, crushing force. Usually this is going to be smashed in a car door, or smashed between two helmets, something like that. This can be protectively splinted, buddy taped. They're probably going to have a subungual hematoma that's going to have to be drained, but it's more than just draining that blood. There's also a fracture under there. If the issue is in the middle phalanx, then usually no buddy tape or no deformity. We're going to buddy tape this. If there is a deformity, we're going to immobilize this. And I've seen, whether it's a padded aluminum splint or a tongue depressor, take your pick. We just need to immobilize that injured finger. In a sport like basketball, we have to be careful. We can't have an aluminum splint, or even a hard shell plastic splint wouldn't be allowed. Whereas in a sport like football, we can pad that up and they can play with that. Proximal phalangeal fracture. These can be spiral or angular. They'll complain of pain, swelling, deformity. We just want to make sure we've got that splinted in the appropriate position, and it should heal nicely. If it's a fracture dislocation, we've dislocated that joint and fractured it, so this can be more complicated. This certainly needs to be x-rayed, and follow-up is going to be pretty essential. If there's just a small fragment, we can buddy tape this one. If there are large broken portions, then they're going to be splinted in 30 to 60 degrees of flexion. So from time to time you'll see somebody in these kind of flexion gutter splints, and you wonder why they're splinted that way. That would be why. Alright, well, that is it for wrist and hand. All that is left is spine. So make sure you finish this week's assignments, and I will see you next week for our last lesson. So until next time.